My name is Opeyemi Adebambo, and today on the issues, our conversation, our focus will be on imaging in hospitals. You might want to ask the question, when we say imaging in hospitals, what exactly are we talking about? Or what exactly do we intend to focus on today? Talking about imaging in hospitals is to also talk about radiology, which is a branch of medicine that uses imaging technologies to diagnose and treat diseases. I am not a medical practitioner. Of course, I have a medical practitioner in the studio who will do justice to the conversation this morning. She happens to be the head of department, the HOD, Radiology Department, General Hospital Ikorodu, in person of Dr. Adedolapo Olayiwola. Good morning to you, Doctor.
Good morning.
It's good to have you in the studio.
Same here.
Thank you so very much for joining us. While my introduction was ongoing, I said today we will focus on imaging in hospitals, and I know that for sure you weren't just compensated with that office as the head of department. It obviously tells that you know your onion so well. That is why you happen to be the head of department radiology, General Hospital Ikorodu. So to have a foundational conversation this morning, a proper understanding of what we call radiology imaging in hospital. Can you help our listeners out there first of understand when we talk about imaging in hospital, when we talk about radiology, what does that department stands for? What is the essence of radiology, and why do we even have radiology?
Thank you so much.
Yes, please.
Yes. Radiology departments in hospitals use imaging modalities, imaging technologies to diagnose and treat. We all know that, a lot of times when we see the doctor, we might have cough, we might have abdominal pain, we might have headache. The doctor will not go in and cut your head to see what is there.
Exactly.
He will not go in and cut your chest to see what is there. We use imaging modalities to view the internal structures of the body. Yes, you have a cough. There are various reasons of cough. It could be infective, it could be cancerous, it could be just anything. So you come to us, your doctor refers you to us, and then you have a chest radiograph done. Based on what we have seen, we're able to say, okay, yes, this is just an infection, this is a mass. Some of us must have broken our bones at some time or the other. Okay, the doctor may just there may be some form of suggestions, that you've broken your bone by you not being able to use it or swelling. But when you come to us and then we take a radiograph of that place, we're able to say, okay, this bone has been broken from this area to this area, and we're able to specifically tell the referring doctor what is going on. So we view the internal organs, and it's not just x-rays. We do ultrasound as well. The ultrasound will tell us what your internal structures look like, your liver, abdominal ultrasound, your liver, your spleen, your kidneys. They are normals. So when you veer from the normals to the abnormal, we tend to see it and then we pick it. Not just the abdominal scan. We do scans of all parts of the body, small parts, the thyroid, the breast, the testes, various scans. Then presently now in a general hospital, the imaging modalities available are the x-rays and then the ultrasound. CT and MRI are also parts of the imaging modalities that are supposed to be in the radiology departments, which radiologists are, familiar with. Thank you.
Thank you very much, Doctor, for that well-defined analysis and explanation for imaging in hospitals. So now this is how we are going to do it. The next 45 minutes of this conversation, I must tell you that a lot of persons might not be fully aware of what we call imaging in hospital and how exactly it works. I as a person, I'll tell you that I know just very few things. When you talk about imaging, the only thing that will come to my head will be X-ray and scans. That is all. But just of recent, I discovered there are more to this. So let's talk about the types of imaging as regards radiology. At least maybe three majorly that are very important and germane. But before we even talk about the types and how it works, I do not want to agree that it is all rosy or all breezy when we talk about imaging in hospitals. There will be some disadvantages or challenges as regards imaging in hospitals. I would like for us to look at it from there. The reason is this. you know, we never used to have all of this imaging in hospitals. This is as a form of development and technological advancement, which is very okay. And we having this, I want to believe that there might be some one or two disadvantages. Some persons will tell you, I don't want to go through any X-ray or scan and all of that. Those things are just technology. They will just come and tell us what is not. We have heard of stories of some people that will tell you they don't go to hospitals because you people that happen to be the doctors will scare them with all of these X-rays and scans and all of these things that comes out from especially your department, radiology. So are there disadvantages that I want to believe? Yes, there should be, or some difficulties or challenges as regards imaging in hospitals?
All right, thank you so much. Well, because we use, especially in the X-ray room,
Mm,
we make use of ionizing radiation.
okay.
And ionizing radiation is like causes teratogenic effects. That means congenital abnormalities
Mm,
in fetuses. So once you are pregnant, in any radiology outfit,
okay.
it's always written in various languages:
Mm,
Yoruba, Igbo, Hausa, English, as well as Pidgin.
good.
Once you are pregnant, you let the radiographer. The radiographers are the ones in charge of the machine. They are like the technicians of the
Mm,
department.
mm,
So you let them know that I am pregnant. Okay.
okay.
If you are pregnant, okay, and then the test is really important, we give
Mm,
you a shield. Like if you want to do a chest x-ray,
okay.
and it's so important, your referring doctor already knows that you are pregnant, and you
Mm,
come to us, we know you are pregnant, we give you a shield, round, to cover, a lead shield. Lead
mm,
shield, breaks the rays from coming to you. It doesn't penetrate. So
mm,
we just give you to cover your abdominal region.
okay.
Okay. But it's important for you to let us know that you are pregnant.
Mm,
And that's basically, that is the only set of people that we do not allow to just breathe in and out of ionizing radiation.
mm,
Then of course you can't keep having chest radiograph every day or every week.
mm.
So we are it's there's a principle called Alara principle: as low as reasonably achievable. The technicians,
That
that's
sounds
the
like a Yoruba name, actually.
I know that's an English acronym.
Okay.
As low as reasonable achievable.
Mm,
Achievable. So the technicians, the radiographers are also trained in handling ionizing radiation, such that you don't come every day for a chest radiograph. You don't come every day for you to get exposed to ionizing radiation, because they have their side effects as well.
mm. Okay, I want to ask you, as a doctor and the head of that department, radiology, we know this is an advancement, a development, which is good. But we never had this before, like I said earlier. In your own words, a convincing way to patients who many a times always get scared. I don't know if I'm to use the word scared or if I'm to use the word ignorance of going in front of any machine and going through that scan or x-ray. Are you saying categorically now that it is safe, it is fine, it is usable, and of course okay for anyone to go through any of your processes?
Precisely, it is safe. It does you a lot of good. It makes the doctor not guess what is happening to you.
Hmm.
It is excellent. It is an excellent advancement in medicine.
Thank you very much for that clarification. Now let's get talking. Right now, let's get talking. We still have 40 minutes for this conversation, so we have a very long way to go. So many questions, and for those of you that are listening out there, you can be a part of this conversation by calling the studio lines and asking questions as regards imaging in hospitals. Maybe perhaps you are out there, you've gone through one X-ray or a scan, or you've done something before that does not seem very clear, or you have some challenges, you have questions as regards radiology. Feel free to call the studio lines 0904 0811061 or 0904 0821061 to ask us questions. We have Dr. Adedolapo Olaiwola in the studio, the head of department, Radiology, General Hospital Ikorodu. Now, talking about imaging in hospital, at what point exactly, doctor, does a patient need to go through all of this scan? Is it something that maybe when situations get bad, worse, accidents, scenarios, or when is it always applicable or advisable for one to, okay, young man, it is time for you to go through another process of radiology, if that is the right word?
And okay, so yes, we don't see patients. When patients come into the hospital, they go through different departments. They go through the GOPD, probably the SOPD or the MOPD. So they are referred to us. So based on the symptoms they have told the doctor, and then based on his examination, he feels that, okay, you had trauma or injury to your skull or injury to your knee. I believe that we want to see what is inside that. So I will be sending you to the X-ray department for X-ray of your knee. So there are various indications. It could be as a result of trauma. It could be as a result of infection. Okay, it could be as a result of pain. Maybe all you are feeling is pain, especially in the elderly patients that have knee pains. There are things that we would see that will tell us that you have degenerative changes of that knee. So whatever we see gives us a clue and gives a clearer, makes it clearer to the referring doctor that this is what is happening to this person. Probably needs a higher degree of imaging modality than what we have, or with this we're able to conclude, okay, or you've had a fracture and then it is not healing well, there's something happening. We just see the internal structures.
And we were on a conversation earlier before that break in transmission, and then you were talking about looking at the angles at which I need you to remind me on there's a particular word you said.
I was talking about why a patient or why a doctor would refer a patient to our department.
Yeah, exactly.
Yes. Okay, so and again for the scans generally, you could have abdominal pain. Maybe you thought you had diarrhea or something. You've used medication, and the doctor just wants to be sure that everything is okay in your system. So he sends you to us to review your your intra-abdominal organs, and then we're able to say fine. Or you have a child that has congenital abnormality, has been vomiting since birth. You come to us, we have the abdominal scan done for the child. There are after the abdominal scan, we may also want to do a contrast study. We also do contrast studies like barium male, barium enema, and all that. To be able to show that is this a congenital malformation in the child or not. So yes, it is really important, because you cannot just, we're not in the rural area whereby, okay, you have cough, take this, and then 2 weeks again you have cough, take this. We have to investigate. So this is one of the investigative modalities of some or most of the ailments people come down with.
I would like for us to then talk about some of these illnesses before we even go to the types. I like the fact that you conveniently mentioned all of these terms and all of that, forgetting the fact that right now you're training into the oceans with all of these heavy medical terms. Before we talk about the types, one after the other, the ones that are let me say very necessary or most common, let us look at some diseases or sicknesses. It is assumed, last week we were supposed to have this conversation, and while we did a broadcast of it, some of the very few questions we got is that are there even sicknesses that requires radiology? The assumption is that when it has to do with scan, maybe there's a broken bone. Those are the commonest. A woman is pregnant, we want to know, is the baby a boy or a girl? A woman is pregnant, how many months? Is it 3 months or 4 months or some weeks? But then it is surprising to know that even some minor diseases or sicknesses might also require radiology, that is imaging in hospitals. So tell us some of the sickness that requires this. Is it just the pregnancy and then the broken leg thing?
No, not at all.
Okay.
In fact, pregnancy scan is yes, very important, but it's not all. Now, it's all encompassing.
Okay.
It's all encompassing. Common cough. Cough could be TB. Cough could be as a result of water in your chest. Cough could be as a result of cancer. Cough could be as a result of just, something, a small infection. Could be as a result of the weather. How do we differentiate this cough is just normal, or this cough is as a result of cancer, or this cough is as a result of TB, or this cough is as a result of water in your chest? Once you do a chest x-ray and it is interpreted by a radiologist, the radiologist will be able to see, okay, this is water in your chest, this is an infection, this is a mass in your chest. Oh, your chest is normal, probably the weather. So he has ruled out 5 different things. They're looking at that. Then for the ultrasound as well, Even the pregnancy scan, we're able to detect anomaly.
Okay.
You know, some children that are born with 6 fingers, some children that are born with cleft lip where there is a gap between their lips.
That would
know.
have been discovered even
Yes,
before they were
yes,
born.
yes,
Wow.
yes. You know,
Wow.
and then a lot of other things. Water in the brain, that's hydrocephalus. You know, those are anomaly scans that we can detect, you know, when the baby is in utero. So you see, it's all encompassing. Mere abdominal pain. Abdominal pain, there's something we call gallstones. You know, you may just be having abdominal pain, You've used this, you've used that, it goes and it comes. And then we scan you. We find out that within your gallbladder, there are numerous gallstones there. You know, about to rupture. That is an imminent emergency. You know, so it is, we find out that there's water. You just find out that your tummy is getting bigger and bigger. You don't know what is happening. And then when we put the probe on you and we scan, you find out that there's so much water in your within your abdominal cavity. You know, that is diagnosing on the spot and helping your referring doctor to say this is it. So beyond broken bones, you know, radiology in fact goes a long way.
Beyond what we think or what it has been assumed,
Yes.
that it is just for pregnancy and then
Broken bones.
broken bones. Still on the conversation, we would accommodate calls, text messages, or WhatsApp messages. You can do that to our studio WhatsApp line 0904-082-1061. That is 0904-082-1061. You can send a WhatsApp message to that line. You could make a voice note as well if you would feel comfortable with that on WhatsApp, asking questions as regards our conversation today. If you're out there, you've gone through a scan, an x-ray, whatsoever, and you feel you have questions to ask as regards this, feel free to do so today. Our doctor is in the studio, and I'm sure she will definitely attempt any question that would be coming from you today. And the studio line is 0904-081-1061, where you can call in directly. One of the questions we have here, maybe we should just quickly attend to this one before we move ahead to other question, talking about some of the errors that occurs in that department, the radiology department. That is when it has to do with mixed results. Maybe, for instance, HIV/AIDS. There are cases where we hear that, okay, this person has been said to be HIV positive, and then maybe after a year or two goes for another test, it is not so, and then the story comes up, oh, it was an error, this and that. Is this something from the technological side of radiology, or this is something from the radiologists, like you said, the technicians that are in charge, or maybe just a mix of results? I think this person needs clarification on where does the error come from when they say this person has this thing, and then all of a sudden, years later or weeks or months later, it is not so.
Thank you so much. Just to clarify, the example the person used, HIV and all that, that has to do with blood workup. We don't do blood workup.
Oh, good.
All we do is imaging. And then we go through a very detailed way of scrutinizing the patients. Okay? Now you come with your investigation, with your request from the doctor. Your name is Ade BC. Okay? We check your EMR number. We ask you for your name. Your name is Ade BC. You go in to have the x-ray done. We key in your name, Ade BC. Apart from that, we put your gender, male or female, and then your year of birth. Okay, those are ways to help us checkmate that if another person comes bearing Ade BC and is a female, definitely the person is not the same. You might not have the same year of birth. Okay, and so when the radiologist is reporting as well, she looks into our system, Ade BC, confirms from the chest radiograph, Ade BC, gender female, fine. Okay, year of birth this, and then begins to report. Reports, puts back the sends the report on. We use electronic media to report, sends the report, okays it, sends it, and then puts the hard copy back in the jacket, ensures that the jacket he or she is putting it inside is Ade BC female with the particular investigation that was sent. So we have, in fact, radiological centers should have almost near 0% error, because like I always say that, okay, somebody cannot come for chest radiograph and then you do the one of the knee or the leg and say that person has a broken fracture, has a broken leg. Whereas, you cannot, it's almost near impossible, because the checking system is very stiff. From when you come to the department, you are being asked your name, your age, your gender, so that goes till your report comes out. All those things are checkmated.
So it is like you said in your words, it is almost impossible to have such errors.
Almost impossible.
So let's talk about some of the types right now. Let's talk about some of it. We are gradually getting there. Some of the major types of imaging, just to help our people have an understanding and its effect, how it works. For instance, if this is called this, what does it does, and how does it work? Let's look at some of this most important imaging.
Okay. So the ones we readily know about now is in this environment, well, in this part of the world, we have the X-rays. Okay, the X-rays are the ones that produce our chest radiograph. They are the ones that produce radiographs of the skull. General X-rays. They are the ones that come in black and white. That's what the layman call it, black and white.
Yes.
Okay, so we have the ultrasound scan. The ultrasound scan also uses non-ionizing radiation. The X-ray uses ionizing radiation. The ultrasound using non-ionizing radiation. Okay, and all of this one uses sound waves. They are all technologies, and then to produce images on our screen, and then we're able to interpret. We have the CT scan.
The CT scan.
Yes, the CT scan. This is more multidimensional. The X-ray will give you a two-dimensional view. The CT scan will give you multi-dimensional view, okay? And so we use it ionizing radiation, and then we use the MRI. The MRI does not use an ionizing radiation. That one is really safe, quite expensive, It has its pros, and all of them have their pros and cons. And then you start, generally in investigations, you start from the least to the highest. Okay, someone will not come to you that you have a headache or you have something, and then it's MRI. There are indications for each. Okay, so we tend to start. Of course, you may skip some and go to some, but at the discretion of the radiologist, actually is supposed to help you to modify your request. Some doctors may not know the appropriate request, especially in centers where all of these, imaging modalities are available. You might not know the appropriate, so we help to modify and to tell you, okay, this will be suitable for this. If it is indication, this will be suitable for this.
Okay, thank you. You mentioned X-rays. You talked about ultrasound scan.
Yes.
And you also talked about CT scan as well. Yes, this one, I want to ask, I am tempted to ask this question that can a man just feel in his own mind and say that, okay, the way I'm feeling, let me just go for either of all of these that you mentioned, X-ray, ultras. The reason is because even in Ikorodu here, when you walk along your axis there, General Hospital Ikorodu, you see centers, you see where you could just walk into and then go through a scan. And according to what you said earlier, if I got you correctly, you said you don't just do a scan or whatsoever for any patients. They would have gone through a doctor who would then refer to any of these scans or radiology departments. Can a man then decide and say, I want to do a scan such as this? If you are saying the doctor will need to prescribe, what if a man then walks to any scan center without going to the hospital and say, for the fact that I'm having waist pain, let me just go and scan myself?
Well, yes. I believe that whoever they are seeing there, if they are seeing a radiologist or a radiographer or a sonologist there, will be able to guide them. For instance, if you have waist pain, you are not supposed to do. It depends, If you have waist pain, low back pain, those things are X-rays.
Okay.
But there might be reasons why you should do a scan of that region. If you are thinking of, other reasons like, kidney problems, and all that. So yes, whoever you are seeing in those radiological outfits that are not, that do not have doctors, or you are not being referred to it, should be able to guide you, sincerely, to say, okay, this is what is wrong with you, this is what you need to do, this is what you need to do. Because I wouldn't want to talk down on any outfit, so to say.
But you feel it is best that they should always see a doctor
Yes,
first?
it's better the doctor refers. It's better the doctor tells you what exactly you need to do.
Regardless of if they are still sure that, okay, this is where the pain is.
Well, if you are sure that you have abdominal pain,
okay,
scan is safe. You can do scan, okay? If you are sure you have abdominal pain, you can. If you are sure that, okay, you were passing by, and of course you were hit by a marrow or something, and you feel that your leg has been broken, yes, You can go to those outfits and say, okay, yes, I was hit by this. I feel probably I have a dislocation or I have a fracture. You know, those things are still mild. But when it comes to highfalutin things like, okay, I'm having headache every morning when I wake up, so I want to do a CT scan. I don't think that's enough reason for you to do a CT scan. It's best you are evaluated by a doctor and then he refers you appropriately.
Okay, thank you for that one. You know, when we talk about medications, let's quickly just tackle this part and then go back to the order of our questions. When we talk about medications, on several occasions we have heard doctors say that don't abuse drugs. Don't assume that because you have headache that the next drug you should take is this particular pain reliever. We don't want to mention names of drugs here. If they say drug abuse, that is excessive use of a particular drug or self-prescription, is that also applicable to your department? Is there any word or is it a fallacy to say that, okay, there's abuse of X-ray? Maybe the man does every month. Let me just be doing X-ray every month to be sure I'm fine. Is there any abuse of X-ray or imaging?
Oh, sure, there is abuse of imaging. Yes. You know, there is abuse of imaging because number one, the X-rays are ionizing radiation, so we do not, you know, it's valid. Whatever X-ray you do is valid for at least 6 months. Okay. So ideally, we ask you, when was the last time you had this imaging modality done? And then that's why it's always good for you to be referred by a doctor, because you already has at least your history to say, okay, this person had a chest X-ray done yesterday. Okay, this person had this done yesterday. But one area we abuse a lot, especially is the ultrasound scan, especially for the pregnant women.
Okay.
Because it is very safe. I can recall when I was pregnant for my own daughter, my first daughter as well. You know, when I was on call every night, I would whenever I'm on call, you know, I'll just want to see what the baby looks like. I'll scan myself.
Boom, go in front of the face.
But it's safe. That is safe. You know, that's just because, you know, I had access to it. You know, I was a more junior doctor. I just wanted to see my baby's heartbeat and all that. Yes. So some women come as well almost every month. You know, they want to be scanned. They want to see how their baby is doing. So we just oblige them really because that is safe. Okay. But of course, for the ionizing one, we don't support you. You know, come in every time. You want to see how your fracture is healing. It's okay. Just leave it. Give it time. 3 weeks, 6 weeks. You can come for a repeat radiograph. Okay. So basically, that's it.
Thank you very much. I must tell you, doctor, you're doing well with the conversation. You know, you talked about pregnancy and you used your experience. You talked about your experience. Now, this will bring me to a very random question every woman out there would want to ask. Many a times a woman goes for the scan. Is it called scanner or X-ray to check?
No,
if it's
scan.
It's a scan,
yes,
right?
It's a scan.
A woman goes and then at what month? There are 2 in 1 questions. At what month would a woman be able to tell if the baby is a male or a female? These are very common questions women would always want to know.
Yeah.
So it is good you help us. That is the first question. At what month would a woman know that, okay, I've gone through the scan, it's a male, it's a female? That is 1. 2, is it the case that every time when the result comes out and say it's a boy or a girl, are we sure that this is 100%? Can you give us a rating of percentage that when the scan comes out to say it's a boy, it will be a boy? Because we have heard of cases they will tell it's a boy and then they go and buy clothes, you know, buy all the clothes and everything that has to do with the boy. So tell us the percentage for that. How exactly does it work?
All right. Thank you so much for that question. Okay. So one of the disadvantages of ultrasound scan is that it is user dependent. Okay. Meaning that it is the person that is using it at that time that is able to interpret it the most. Now, gender. Yes, I know a lot of women come in for gender. They want to know if it's a boy, if it's a girl. We call something gonads. Gonads is what differentiates a boy from a girl. Okay. You know, a man from a woman. Okay. So those things are not formed till 16 weeks. That's about 4 months. 16
weeks.
Yes, in utero when the woman is pregnant. Okay, so anything from 16 weeks we can know your gender. Now, knowing your gender is a very funny way. You know, the thing is that it is not computed in the ultrasound machine that this is a boy, this is a girl. How do we get to know if it's a boy or a girl? Yes. Now, when you are scanning the baby, you know, and the baby opens up the thigh, and you see the phallus, the penis, you're able to say this is a boy. And then on the other hand, once you don't see it, you know, this is a girl. That's how we know it. But the other thing that makes it very confusing is that I don't know if you have seen a newborn girl before. Sometimes even the labia, the area of the where the genitals will be, is swollen. Okay? So sometimes some people mistake that to be the testes in a boy, when they are pregnant. You know, so it has to be, the person interpreting it has to be sure that, oh, from my years of experience, I am so sure that this is a boy, I'm so sure that this is a girl, based on the phallus. Just like what I always tell women, pregnant women, is that just like when you deliver your baby, the baby will be brought up to you, and then it's whatever is dangling between the thighs that you're able to say that, oh, obìnrin ni mo bí o, ọkùnrin ni mo bí o, it's a boy I have delivered, it's a girl. That is the way. There is no magic in it. And funny enough, you know that the way the uterus is and the way babies are always, you know, like flexed, you know, with their thighs together and all that. Some children, you can spend 15 minutes scanning them, they won't open that leg. You will not even see anything. Whereas some children, you know, some people will say, I don't want to know the gender, whereas the penis is dangling in front of you, but the woman doesn't want to know the gender. So what am I saying? Ultrasound is user dependent, and it's best for us to be honest, even at this my level. Once I do not see the phallus, once I'm not sure that this is not, you know, the phallus, or this is clearly not a girl, this is clearly not a boy, I tell them I'm not sure. But when you come for your next scan, please ask me again, you know, and I encourage as many people that I have trained over the years. You know, this is a very touchy one. You can't tell a woman today that you're having a boy. She comes today, you're having a boy. She comes tomorrow, you're having a girl. She comes again, and then she eventually delivers. So it's better you let them know that this is how we see this thing. And for now, we have not seen the gender of your baby. But please, when next you come, ask me, and I will tell you. And then the other thing is that the baby gets bigger. You know, the uterus is just, it's all like this. So as the baby gets bigger, everything gets tighter. So the earlier we get it, some people will come at 9 months, they want to know, hey, this is tough. Your baby has added so much weight, you want to deliver next week, you want to know your gender. We try, we maneuver, okay, lie this way, lie to your left, lie to your right, all so that the baby would open the thighs, you know, and all that. So that is just it. There is nothing in the system that tells you that this is a boy or a girl. It is you with your eyes that you say, okay, I've seen the penis, you know, I've seen the labia majora and the minora. This is a girl. I've seen this. So that's just.
I want to say thank you for that clarification, because we used to think, you know, the system right in front of the radiologist would just write something BOY or GIR.
XY, XX.
Yes, that also comes up, and that is, I think, a way of translating the gender. So which is XY, which is XX? XY
is the boy. And then XX is the girl.
So XX is the girl. Maybe that is why they always wear extra large, you know. so now you said something about cases where at that particular time you might not be able to detect, and then you tell them to come back. There could be another. It's something that you could do again. It has no implications whatsoever.
No. It doesn't use ionizing radiation. You know, I gave the example of my own self as a junior doctor in radiology. Yes. Anytime I was on call, every 3 days, I want to see my baby's heartbeat. I want to see the baby moving. You know, I did that. And a lot of my juniors also did it. You know, we just go scan ourselves. My baby's
free now.
So that's
yes, and if you're listening, I think our doctor has cleared the air on that. And to be able to determine this, it is usually somewhere around that 16 weeks.
Yes.
I think he said that 16 weeks, which is approximately 4 months. Now, let's talk about the difference between X-ray and scan. If at all there are differences, we want to be sure. People misplace these two together. Sometimes they just tell you, I went for an X-ray, and meanwhile, they actually went for a CT scan. Sometimes they tell you they went for a scan, meanwhile, it happened to be an X-ray. What's the difference between the X-ray and then the CT scan?
Okay. So, both of them, one of the similarities is that both of them use an ionizing radiation. This CT scan now, not abdominal scan.
Okay.
So CT scan and X-ray gives you, obviously, CT scan is more expensive.
Oh, okay.
Oh, you can't do CT scan for probably anything less than maybe 30,000-40,000, you know. And then there are restrictions for you. You have to have your electrolytes, urea and creatinine done, because you'll be given contrast. and they want to be sure that your kidneys can excrete the contrast. So you can't just walk in and have a CT done, in quotes. But yes, and a chest X-ray, you can walk in and have the chest X-ray done that day, even if you have eaten, if you have not eaten, okay. And then the the radiograph, the X-rays are two-dimensional images. You know, the CT scan are multi-dimensional, meaning that, you know, when you scan the skull now or the brain, you can actually come out, you can reformat it like a real skull or a real brain. You can turn it around and you can see the back, see the front, see inside, see the vessels, see everything. Whereas in X-ray, you cannot do that. All you are seeing is black and white. Black and white. If we have done any X-ray before, we know that all you see on a radiograph is black and white. Because why would you want to spend 40,000, 50,000 on something that you do not need?
On assumption.
Okay. Whereas, you know, spending like 5,000 or less would, you know, have solved it. Yes.
Okay, so let's talk about medications now.
Okay.
And let's help our listeners be sure if this is what your department, the radiology department, also covers.
Okay.
At the point where a radiologist, you know, goes through whatever they have to do in your terms, is it your duty to then say that because we have checked this, we discovered that this is what is wrong, this is what is wrong? Is it still your department that would then prescribe and say, go get these drugs, get this particular one, this is how you use it? Is that also your jurisdiction?
No, please. That is not the jurisdiction of a radiologist. We only diagnose. We treat sometimes when we have to do interventional stuff with our machines. Like if you have fluid in your abdomen and we have to drain, if you have a cyst and we have to drain, you know, we do a few things, but we do not prescribe medication. So you go back to your referring doctor.
So as soon as you discover what you have to discover, you go back to your doctor. Okay.
Yes.
Okay, that is fair and quite understandable. Talking about broken bones now, fractures and all of that, that is another core side that people will want to know about. When it is said that a man has a broken leg, for instance, maybe due to an accident, depending on how the case may be, how then can you tell that, okay, this bone that is broken, it is broken in 3 places? Is there the reason is because you just said it yourself that for pregnancy you can't tell if it's a male or a female. We can't tell if it is XY or XX. So if we cannot tell for a fact this is how it is, then how can we tell for a fact that this bone got broken in 3 places? They will stitch. Do they even stitch bones? I think they remember. How does that work for broken fracture?
Okay, thank you so much. In fact, if the bones are broken in 10 places, we would see it and we'll tell them.
Okay, that comes clear.
It comes very clear. You see it. Even an untrained eye will see that, you know, this is broken, this is broken, this is broken. We'll see a breach in the cortex.
Okay.
You know, bones are usually straight line. No matter what, bones are straight line. You know, so you see it, you see it, you see it, you see it. The only one that may be dicey is for children, and we call their fractures torus fracture. TORUS fracture. That's because sometimes we just be a buckling of the cortex that would tell us that this child has a fracture. Okay, or an effusion of the joints. I'm going into radiology, but really, it is diagnostic for fractures. Yes, please.
And it gives the accuracy.
Yes,
it gives accurate details.
Yes,
okay, before we let you go, you have just 5 more minutes, but we want to thank you for your time. I am also very much aware that you have a lot on your decks for today, but then you spread out the time. Thank you for that opportunity given to every listener out there. Let's talk about reasons to why people should feel comfortable before you then give us your parting words.
Okay.
As I speak with you, we have people who just have the phobia. There are people like that. I don't know if you've met them across your line of professionalism, where they will just tell you, okay, this is wrong with me. I don't want to go. I don't want. So also we have people who don't want to even take injections. We have those that don't want to take drugs. But those that have this phobia with your machines and technologies, how do you handle them? And how can you convince people at home right now listening to you that there is nothing? Just come, let us chuck you inside the machine. And then I think there are some of your machines that will just drag somebody inside. The person will just go for some minutes and then come back all refreshed. And how convincing could this be?
Thank you so much. Actually, some of our machines can be very intimidating, especially the MRI and then the CT scan. In fact, children cry and cry. We may have to sedate some of them. Okay, but those are for the CT scan and MRI.
Okay.
You know, people that have claustrophobia, that are not, don't want to be left alone in an enclosed space, we sedate them. Okay, those are for CT and MRI. Well, for the X-ray machine, yes, you enter and you see this hanging there, this like this,
the
this
lightning
like that.
and all.
So we just allay their fears. We just tell them, you know, this is what you're supposed to do. This is what this machine would do. This is what this would do, and all that. There hasn't been very acute cases where we've had to sedate.
Okay.
You know, there hasn't really for the X-rays, but for the CT and MRI, that is almost every time. But for that, yes, there, you know, some elderly patients, some of our parents will bring from the village, or our uncles and all that. You know, we just explain, you know, this is supposed to help us to see this better and all better. It might take a little while before they calm down, but you know, we need them to calm down, because not cooperating, you haven't done us any, you have just wasted your time, wasted my time, wasted your money, wasted other people's time waiting outside. So you need to be cooperative when it comes to radiological investigations. You are not forced to do it all. Nobody comes and holds you bagang.
By force.
Nobody does that. It's something willingly. The only people who force are the people from Majidun, people that are not very, you know, well oriented. You know, we just get a few people to hold them down.
Okay.
You know, so that they can just take the images and all that. But and then for the uncooperative children, to sometimes we've had to give them maybe Phenergan and all that. We've had to send to the doctor, this patient, this is your baby. If you want a good image, it's better you just help us sedate slightly, you know, or the mother, usually for babies, the mothers always have to be there to calm them down.
So, so your department, you use bouncers, because you said, for instance, people from Mad, they will have to hold them down.
No,
the doctors are the ones that
no, you know, it's not even ethical, because you cannot keep holding all patients down. You are taking ionizing radiation. They have people that bring them.
Okay, so they should do that.
They have people that bring them. We explain to them, and then they wear a lead jacket. Lead jacket, you know, it transmits back the radiation, such that if you have brought 5 patients for X-ray and 5 of them are not cooperative, it's unfair for you to take all of the radiation. So we explain to you, bye, Neil, but we'll give you a lead jacket just for you to stabilize. It's against the ethics for even a radiographer, the technician there, to hold patients, because it is how much radiation do you want? Apart from you, it's been an occupational hazard to you, you know, been working there. Why would you want to take in other people's radiation? You know, so
because I was wondering, you know, when you said they will hold them down, I'm already thinking some of your doctors will have the muscles,
their relatives,
your radiologists to have that muscle and everything. We have just 3 minutes to leave the studio. Again, I want to say thank you so very much, Dr. Ade Dolapo Olayiwola, for doing justice to the conversation, helping us have a very clear understanding as regards imaging in hospitals. Now, your parting words before you leave the studio to everyone listening to you. You have 3 minutes to convincingly help them understand that your department is safe.
Okay, thank you so much. So radiology departments everywhere in all hospitals, okay? It's a very safe place for you to be examined, you know, thoroughly, especially when you have reasons to be referred by your referring doctor to us. It's a safe place, you know. The results are almost near perfect. When we say you have this, we're almost 90% sure, if not 100% sure, that you have this, okay? And then the radiologists work with a team of radiographers. They are the ones that, you know, that take the images. The darkroom is in extinction now, so we really don't have darkroom people again. And then we have administrative staff as well, you know. So when you come in, don't be scared of the machine. Don't be scared of, you know, just let us face our focus. And then, you know, trust that, you know, whatever ailment you have brought will be detected, and then your referring physician will be able to tackle it appropriately for you. Thank you.
Thank you so very much. So if you've heard this and you've learned in a way or the other, feel free to look for Dr. Ade Dolapo Olayiwola. She's the head of department, radiology department, General Hospital Ikorodu. Whenever you are referred to that department, just say, no, I want to see the HOD. That is the voice. And we say thank you so very much for your time. This is how far we can have it today on the issues where we've taken our time to talk about imaging in hospitals, the essence, the beauty, and the reasons why you should subscribe to this. It is of no harm, rather it is of good than harm. And next week, Thursday, will be another very good time on radio to talk about health conversations. But of course, tomorrow is another good time on the issues. My name is Opeyemi Adebambo, urging you to stay safe, stay healthy. Of course, your health is your wealth. God bless Lagos, God bless Nigeria, God bless Ikorodu. And again, I say thank you to our doctor for joining us.
Thank you.